Okay, so I'd like to welcome you all to this session around the planned care programme. Before we start, just a couple of housekeeping points. So mainly around kind of keeping your microphones on mute. By all means, have your camera on, that's fine. We hope to have time at the end of the session for any questions. So please put them in the chat bar as we go through or at the end, and also feel free to raise a hand at the end of the presentation if you want to ask your question verbally. I'd like to start by introducing myself and my three colleagues who'll be presenting today. So my name is Amanda Portlock, and then we have Amanda Russer, Jane Imperato, and Daryl Harris. We are the four regional leads which make up the Improved Clinical Decision Making Programme team, known for short as the ICDM team. And as a programme, we're part of the transformation team that sits within Health, Education and Improvement Wales. So if I can have the next slide. Okay, so as part of the planned care programme presentation, we've been asked to introduce the care aims framework and how this aligns with the 5 goals of the planned care programme. The full title for care aims is the Intended Outcomes Framework. This highlights the importance of beginning every decision by clarifying the outcomes that are intended to be achieved by that decision. And by outcomes, we mean the impact on well-being that we are trying to achieve. Once the outcomes have been identified, the next consideration is what results or outputs we would be looking for that will help us to move towards those intended outcomes. Finally, the next stage of decision making is to identify the tasks and actions needed to achieve the results. So in this spirit, the wellbeing outcomes that we're seeking from this presentation are for us all to be energised by a shared sense of ambition, and we invite you to consider joining us in the revolution of wellbeing. Moving on to then the outputs, so the results that we'd be looking for is a shared recognition that something needs to change, doing the thinking together, and identifying shared ambitions and opportunities where we can support each other. And then finally, what would we need? What tasks and action do we need in order to achieve these results? So as part of this presentation, what we're aiming to do, we brief introduction to care aims, how this might apply in planned care, and also have the opportunity to for you to ask questions and we can have a bit of a discussion.
So what we're going to look at now is the nature and scale of the challenge, which it has to be said is just a tad daunting, really. So the figures for November 2021 showed that the overall waiting list for treatment was standing at 682,279, which actually equates to 21.5% of the Welsh population. That's more than the populations of Cardiff, Wrexham, Carmarthen and Bangor combined. According to Cardiff University, it will take several years to clear the backlog in elective waiting lists post-pandemic. Costs are estimated as being between 152 to 292 million over a 4-year period. And that's the NHS and the Welsh budget, Cardiff University. The OECD recognises that Wales is the most economically deprived of the UK nations, and that this lower income per head has likely impacts on health and well-being and demand for NHS services. And we have quite specific problems in Wales, in that 61% of adults in Wales are overweight and 25% are obese. And we also have this, so we have these health inequalities going on. And we have 800,000 people in Wales aged over 60, of which I am one, okay, although I feel very youthful. And around a third of our population is at least 75. And we know that tackling inequalities could actually save hospital in Wales 322 million every year. So guess what? That's the equivalent of a brand new NHS hospital or the yearly salaries of nearly 10,000 extra nurses every year. Those figures are from Public Health Wales. So in brief, the problem that we're facing is we've got these higher expectations from people, the population generally. Okay, we have less financial resources, so we're financially squeezed, and there's a need for greater fairness and equity when we're using those resources as well. So we have a whole plethora, okay, of national strategy documents that have been published, outlining plans for how we as a nation and as health providers might meet the challenges that I have just outlined. Okay. And I'll go through some of those documents, because if you're like me, it all ends up as a blur in your mind, and you tend to forget which one is actually which. Okay, so we have a Healthier Wales, and that's making it easier for the NHS and social care to work together in a joined up way. And it also states that they should be working with other services like education and housing to help people stay healthy and independent for as long as possible. It particularly emphasises the importance of community care and person-centred care. The National Clinical Framework describes how clinical services should be planned and developed in Wales based on the application of prudent and value-based healthcare principles. We're always hearing about prudent healthcare these days, and we refer to it as being prudent in practice. And it also recognises the need to shift focus from hospital-based care to person-centred community-based care. The current pathway approach is not as seamless or as complete as it needs to be, and it can actually have the opposite effect to that which is intended, in that it can sometimes create a suboptimal patient experience. So, tackling inequalities could save hospital in Wales 322 million absolutely every year, as we've said. So the report Health and its Determinants in Wales 2018 shows that the leading causes of disease burden are cancers, cardiovascular disease, musculoskeletal conditions, mental health and substance misuse. Much of this disease burden is preventable, and further effort is needed to reduce the burden of avoidable ill health on people and the NHS. And there's a body of research showing that overtreatment and overdiagnosis produces real harm to patients. It is important that our focus on pathways does not drive patients into interventions that are not in their interests or are unlikely to deliver the outcomes that they want. The Social Services and Wellbeing Act states that it is important to put the individual and their needs at the centre of their care, giving them a voice in and control over reaching the outcomes that help them achieve well-being. That is known as voice and control. They also talk about prevention and early intervention, increasing preventative services within the community to minimise the escalation of critical need. And also well-being, supporting people to achieve their own well-being and measuring the success of care and support. And lastly, co-production, which is about encouraging individuals to become more involved in the design and delivery of services. So all of these acts and all of the principles behind them overlap, which is why sometimes, as I've said, you can almost get a brain fog with them because they are all so similar. They're all very much saying the same kinds of things.
Okay, so the one important thing that is acknowledged in these strategy documents is the absolutely critical role and the value of our staff in all NHS and social care organisations. Dr. Frank Atherton, the Chief Medical Officer for Wales, stated that if we've learned anything in the last year, it's that our workforce is our greatest asset. So one of the many reasons NHS staff are such a huge asset to the organisation is that their best hopes are so well aligned to this national strategy. So in terms of the national strategy, the outcomes, so the intended outcomes and the reasons why these things are important, I'll highlight it as improved population health and wellbeing, a focus on what matters to people, fairness, and as Jane mentioned, equity and justice. They facilitate autonomy, and they enrich the wellbeing, capability and engagement of the health and care workforce. So through undertaking care aims training, we start each module of learning by recording and understanding the staff's best hopes for their own work, for their own patients and for their own services as they come into the training. And we know that staff prioritise and hope and share the same ambitions highlighted in these documents. Put another way, they're seeking the same outcomes as the Health Minister, the Chief Medical Officer, the health boards, the health board execs, and hopefully our communities. So this is a summary of the best hopes for people who have attended the sessions, and we've taken these in terms of themes and put them together. So people's lives will be better because we are listening to what really matters to them. They'll feel more confident that the services will help and that they'll be able to get on with their lives. People will be less reliant on services to meet their own goals, recognising their own resources and strengths. There'll be more autonomy and freedom to make decisions. There'll be greater fulfilment. What we will be doing, what we've been trained to do and not what we're told to do. We'll feel more at ease and at peace with our decisions and not always knowing the answer, having that uncertainty and being able to hold it. Feeling more valued by our patients and their families. Trust will be increased because of improved communication, and we will be feeling valued as individuals, as teams, as services. There'll be less stress within our working lives and everyone will be happier. There'll be better morale, better team working and attitudes. Everyone will be feeling safe, supported and effective, and stress would no longer affect our home lives. So, I mean, these are quite big hopes, and I hope you share with me that actually these things do impact us on a daily basis, but they're not always the things that are discussed or come across in the strategy documents. So, to reiterate, the high-level outcomes, so the intended outcomes, and the clinical opinions of our staff are aligned. So there's that link between outcomes and best hopes. Our best hopes are the starting point for undertaking both the care aims training, but also a care aims approach to clinical decision making. In order to transform, we believe there needs to be clarity around this intended outcome and the reasons why before we decide the outputs or results that will contribute to this intended outcome, and before deciding the inputs, so the tasks and actions that will achieve these results. And this is very different to traditional QI or any sort of change process. So as we've just gone through, these are the intended outcomes that are highlighted in the high-level strategy documents, and these often define the overall outcome, the goal, and they can include the outputs. So for these high-level strategy documents at the moment and working into planned care, we're still looking at a population focus, a lifespan approach, and that's very much talked about in the National Clinical Framework, prevention, prudent use of resources, integration, focus on value, moving care into our communities, as we've said, so care closer to home where people, value the support in their own homes and communities, continuous learning of staff and the ability to access that, greater self-management, patient-centred care, and even I would go further and say person-centred care, in the right place at the right time. And so, sorry. However, the strategy documents don't always specify these actions and decisions to move towards these outputs. And when they do, they can be restrictive. For example, prudent healthcare will outline the outputs, but not how to achieve them. However, the National Service Framework goes on to refer to these actions, so the tasks and actions needed to achieve the results, as being prudent in practice. The National Clinical Framework highlights the critical importance of decision making. What we hope to illustrate through the remainder of this presentation is to illustrate how the Care Aims framework might help to operationalise the outputs highlighted in the previous slide. For example, turning the principles of prudent healthcare into prudent in practice. The decisions we make as clinicians, as service leads, as managers of services, bridge, are the bridge between our hopes, our aspirations, and the impact we have on our patients' lives. So in order to achieve our valued outcomes and those of the people that we work with, clinical, strategic and operational decisions need to be underpinned by a thorough understanding of what matters to us and the people we work with. This is at the heart of the care aims framework and the beginning of any decision-making process. As we've already suggested and hope to show further, this is currently not always the case. Often, even when we think we're practicing in a person-focused way. In a study conducted by the Joseph Rowntree Foundation, 79% of staff thought that they were providing person-centred care, but when surveyed, only 13% of recipients thought that they had experienced person-centred care, which has quite a big impact and quite a big implication for the fact that we are not being able to shift this person-centred approach into the lives of the people that we're supporting.
So now we're going to have a little look at the planned care programme and the 5 goals. So just to reiterate that planned care is any treatment that doesn't happen as an emergency and usually involves a pre-arranged appointment. Most patients are referred for planned care by their GP. In November 2021, Elynyd Morgan recognised the significant impact of the pandemic on planned care and the fact that it had resulted in this massive backlog of patients waiting for planned treatments. So she then gave a rallying call about the need to build a planned care system that is bigger, better and more effective than we have ever seen before. And at the same time, Judith Paget outlined 5 goals that she proposed would help to transform planned care, so that it is those 5 goals on the screen. These goals can be seen as helping to bridge the gap between strategy documents, like the National Clinical Framework, and service delivery. So the 5 high-level goals for planned care can be thought of as being outputs. In other words, they're results that will contribute to the well-being outcomes outlined in the various strategy documents, and that is actually illustrated within the next slide. Okay, so how is always the big question, isn't it? So our strategy documents set out the high-level outcomes that we're actually seeking, and they can be translated into the results that, if achieved, will move the service towards the outcomes that we want. So clinically, we translate these results into the decisions and actions that are required to deliver the actual results and outputs. So in the case of planned care, this looks like something like the figure on the slide. Now we want to illustrate how the Care Aims framework provides a set of principles that enables practitioners to turn the planned care goals into actual defensible clinical decisions and concrete actions by linking some of the key Care Aims principles with each of the actual planned care goals. So for each goal, what we're going to do is we're going to briefly summarise historical practice and then think about how the Care Aims principle can provide us with an alternative perspective. And we're actually going to start with effective referral.
Planned care programme defines effective referral as ensuring that referral guidance and thresholds are in place to ensure that the most in clinical need are referred to the appropriate setting. This raises the question of how do we define clinical need? Traditionally, referral guidance has offered problem-oriented thresholds which define the nature and level of clinical need that warrants referral and then admission into specialist services. These criteria then define the focus, tone and language used in conversations we have with patients. We suggest that the focus on problems in clinical discussions can have important consequences. First, they can distract us from exploring what really matters to patients. This means we risk providing interventions that quite simply miss the point. This in turn leads to people representing at services on multiple occasions or referrals to different services for the same problem. John Seddon calls this failure demand. This can also lead to lower levels of satisfaction and can have an adverse effect on outcomes or intended outcomes as people deteriorate as their true needs are not known or met. The second reason we're concerned about the impact of focusing on problems with patients is that the language we use influences the message we communicate to them and to our colleagues. So problem-oriented referrals and discussions sends a subtle message to service users. They say, you need to be fixed by us. You are expected to change. You're expected to change to fit into our service criteria or our services. You're not able enough, so are dependent on us. You're unhelpfully different from the normal. You're not safe and need to be rescued by us. In contrast, exploring and then communicating impact as part of the referral and triage process communicates a very different set of messages. We need to understand you. We want to include you. We will learn to tolerate difference better so that you can be one of us. You are unique and you are enough just as you are. The key thing is that the former messages promotes dependency. The latter fosters and supports self-reliance and autonomy. The risk of dependency is that it creates learned helplessness and risks causing harm by undermining people's sense of autonomy, responsibility and agency. And in doing so, maintains and exacerbates demand on our limited health and personal resources. Another potential problem with referral thresholds is that they can contribute to a culture of scarcity. So fearing a flood of demand, we use our referral and entry criteria, as well as other steps, as a way to manage demand. This can have the perverse effect of making people try even harder to get into our services, further exacerbating waiting lists. This can cause harm in a number of ways. Harm caused to people during waiting times. Staff feeling overwhelmed, demotivated. We're not doing enough. We're not doing enough well, and feeling at risk of criticism, fearing that the enthusiastic COVID hand clap for the NHS turns into a slow hand clap of complaints over waiting times. So what's the alternative? Care Aims focuses on creative, effective conversations at the referral boundary. These conversations are underpinned by a number of principles. A referral is seen as a request for advice, for support. It's a request for collaboration and not a transfer or handover of care. The focus of referral conversations is risk or impact to well-being. The so what, the impact of the problem, not the problem itself. This is deeply personal and individualised. This means that following this principle guarantees a truly person-centred approach. For example, the reason for me having a hip replacement later this month is because I'm not able to access sites at work due to hills or stairs. I'm unable to play with my children in the park, unable to go hill walking or do other activities that are important to me and that also get in the way of me socialising with friends. So the outcome of my hip replacement will be very personal. It'll be different to the person who's scheduled before and the person who's scheduled after me. The impact of any health condition depends upon individual context and circumstances. And this is at the heart of Care Aims. The example of my hip replacement illustrates the difference between my surgical need and the impact my surgery will have on my well-being. The left-hand side of the slide that's up at the moment illustrates needs that research has shown we all have and need to meet in order to live well. Within the Care Aims framework, at referral, the initial duty is to the referrer or the person requesting help. The aim being to understand their concerns, the impact on them, as well as the other people involved. The idea is to map and have an understanding of the pattern of concern across the person's circle of support, and this is illustrated on the right-hand side of the slide.
Okay, so we're going to move on to the second goal within the planned care programme, and this is around advice and guidance. And the planned care programme defines this output as developing access to high quality advice and guidance to enable informed decision making for individuals, as well as primary, secondary and tertiary care clinicians. So when using a care homes approach, the importance is placed upon understanding who is bothered, why are they bothered, and what impact this is having on their life. And this is based on an understanding of what matters most to them. This can be achieved by listening to our patients, or those people closest to them, or the person who is most concerned, and allowing them to express their own perception of the patient's needs and the impact of this problem on the patient's life. Until we know what's important to patients and those closest to them, and how their health needs impact upon what is important to them, how can we know what advice will be helpful? So then we move on to the third goal, and this one is around to treat accordingly. So again, the planned care programme defines this goal as access to the appropriate care at the right time and the right place. A similar issue arises with this goal as with the last one. How can we know what the appropriate treatment is and when it is most needed until we fully understand what matters most to a person? We're constantly being reminded in the media about the size of our waiting lists, and one of the challenges that is not addressed in the media, but what we all face, is how do we prioritise people on our waiting lists? In terms of the planned care programme goals, what is the right time? Or perhaps more realistically at the moment, what is the least worst time? From an ethical point of view, our duty is as public servants is to do as much good for as many people and as little harm as possible in a fair way, whilst respecting people's choices. This suggests that an important consideration in prioritisation is the level of potential harm being caused by waiting. This raises the question of how we define and measure harm. There are at least two ways of answering this question. So firstly, traditionally harm is defined in biomedical terms, and there is harm to physical function. But secondly, in the Carings framework, harm is defined in terms of impact on what matters and impact on well-being. It is important to recognise, although these may be linked, this is not always the case. It is by no means unusual that the well-being of people with the same level of physical impairment can be impacted very differently. And to give an example of this, we've looked at and taken an example of cataract surgery and how that impacts on well-being. So two different individuals, patient A, and in their words, I don't need this surgery I have been listed for. It is my preference not to have this. Why? I am well looked after. I don't need to have it done. I'm not bothered. I don't want the hassle and the pain and the fear of going through surgery. So our second individual, patient B, I need both my eyes doing. I am the carer for my husband with mild dementia. I manage the whole home, the house and all the bills. I need to be able to manage all these tasks in order to remain independent. So the question is, does treating accordingly mean treating according to predefined gold standard treatment options, or according to what matters most to them? Just trying to find my list. Right, okay, so then we've come on to the final two goals, which are, the first one of that is follow up prudently, and this is around giving individuals more choice and control over their care. So one way of thinking about care aims is as a way of translating prudent healthcare into prudence in practice. I hope that we've already illustrated that care aims is not just about giving individuals more choice. Instead, it is about embedding the question of how I can facilitate autonomy into every clinical decision and stage of care. Decisions are underpinned by a clarity about duty that recognises the relative risks of over as well as under provision. In every decision, practitioners are weighing up risk and impact to wellbeing, the ability of people's circle of support to manage identified risks and impacts, and the minimal intervention that would be required to allow the person and those closest to them to manage risks and impacts independently. And this includes working with them to identify the necessary safety nets required to manage future foreseeable risks or impacts. And then the fifth goal is measure what's important. And this is around transforming care to better meet the clinical need of the patient. So on this, we note that care aim focuses on risk and impacts on wellbeing caused by clinical need rather than clinical need per se. We have outlined one set of reasons for this shift in focus. Another reason is provided by a piece of research conducted by the Mayo Clinic in the US. This research found that for members of the community, health was not defined as the medical community defines it, which is as the absence or presence of disease. Instead, community members defined health in terms of the ability to meet their social obligations, with wellness being described as having a high quality of life. This suggests that in measuring what is important, what we see as important might not correspond to what our patients do. And in care aims terms, this is acknowledged in measuring progress towards personal outcomes, as well as more clinical outputs. If we are going to measure what's important to patients, we need to start seeing the world through their eyes.
In the forward to the National Clinical Framework, Vaughan Gethin notes, we've arrived at an important crossroads in our history, and the decisions that we take at this time juncture will determine the health and well-being of current and future generations of the Welsh population. So here we are at the crossroads. Elsewhere in the National Clinical Framework, the message states, the message is don't wait to be told. This framework is your permission to act. But it's important we remember, cofiwch, before deciding which path we take, we need to clarify the outcomes we are seeking. These should then be our guide and our measure of success. One other closing thought is that change is difficult and anxiety provoking. It involves embracing uncertainty. But if we always make the same decisions, we'll continue to get the same results. Care Aims offers a set of principles that in our experience can lead to greater clarity, autonomy, prudence, and a positive impact on our decision making. Our experience is shared by many other practitioners in Wales and more widely, who are already familiar with the Care Aims framework. Although much of the framework might be familiar, our experience is that applying it and applying the principles can require us to rethink and clarify important assumptions that underpin our decision making in practice. We hope that during this presentation, we've at least piqued some interest in whether the framework might be helpful and might help you to move towards your best hopes.
So, if you are energised, feel a shared sense of ambition, or want to join our revolution of wellbeing, please join us. Please, we are a resource to be very much used by you all. And we actually have on the next slide, we have bite-sized workshops which are offering networking opportunities. We've got care aims training in the offing, and we have a variety of new web resources that we're in the process of developing. Some of our training is going to be online, but now we're in a position where we can start to offer face-to-face training again, which I think will be absolutely great. Our emails are on the global system, okay, we all work, well, apart from me, because I'm very ancient and I have partially retired now, but everybody else is still working in practice. So don't fall into the trap of using the wrong emails, because HEIW have a specific HEIW thing on our emails. Okay, but we'd love to hear from people. We're taking referrals. On the whole, we're working with HEIW and the Strategic Health Board leads in order to get our referrals, because there's a concern that we might be inundated, because we only work 2 days a week. So we're a relatively small resource, and we are actually to be utilised across the whole of Wales. So we do have to, like the waiting lists we've just described, we also have to prioritise accordingly. So there is an element of prioritisation, but at the moment, you know, we're still getting known, I suppose. So there's a window of opportunity to use our services, and we're delighted to hear from people. I've been checking in the chat box there. We haven't really got any questions in that chat box, but as there are so few of us, okay, it would be actually great if people wanted to raise hands and ask any questions following the presentation. We hope that you've got something out of it, and that you've enjoyed it, and that you've understood what we've been trying to get over. And thank you very, very much for giving up your time this morning to join us in this meeting. Okay, and then just to reiterate, these are the areas that we cover. As I've said, I'm Jane in Parato. I actually live in Cardiff, but I'm covering Hywel Dda and Swansea Bay, UHB. I'm from West Wales originally, so I know the area pretty well. And then we, as we've already mentioned, Amanda's covering WAST, Public Health Wales, Velindre, Cardiff and Vale UHB. Amanda Rutter is trekking up to North Wales, Betsy Cadwallader and Powys, and Darrell is doing Cwm Taf Morgannwg and Aneurin Bevan. Okay, so do we have any questions from anybody? Do not be shy. Even there's a gentleman I know who is a ghost, really. He's invisible on the chat because his webcam is not working, because somebody's probably stolen it, because resources within, let's face it, resources are scarce, aren't they? So we borrow off each other all the time. But did anybody want to ask any questions? Or was it all totally clear? It was all I'm getting a nod. It was all totally clear. How marvellous.
Just wanted to say Wendy's put a link to our HEIW resources in the chat box. If you're watching this on the replay and you haven't got access to the chat, please feel free to click through to that resource. So if you just Google improved clinical decision making and HEIW, it will come up with our page. There's a number of resources on that page you can access, and one of the masterclasses that Kate Malcolmus, who is the creator of the Care Aims Intended Outcomes Framework, did for the Health Board execs back in last May. So please feel free to get in contact with us. Our emails are also, I think they're on that web page. And if there's any questions, if you're watching this on the replay, then, you know, please do feel free and get in touch.
Yeah, and actually the emails are on Global as well. Oh, Wendy, you had a question.
Yeah, I guess it's just a really great presentation. Thanks everybody. I agree with the comments, you know, really informative and very clear. I guess my question was around if somebody is in a team thinking this could totally help me, this is exactly what we need. Do they contact you directly? Is there anything else they need to do? Anybody else within their own organisation they need to talk to before they come to you?
Well, officially there is somebody nominated in each health authority who is supposed to be spreading the word, and the referrals are supposed to go through them. Okay, but I think if they wanted just to raise the issue with us, if they wanted to ask us a few questions, we'd be happy to speak to them anyway. And whether or not we could actually action their concerns immediately because of this prioritisation process is another thing, but certainly we'd be more than happy to speak to anyone who wants to know more.
We can also signpost them back to speak to the health board leads as well, so that we can make sure that the needs are aligned for the health boards and the strategic priorities for the health boards and HEIW.
And when it goes back to that, is that idea of a referral being a request for help. So if people have an issue and they would like to make a request for support or advice, get in touch and we'll do our very best to do that.
Brilliant. Thanks, everyone.
And there are new resources coming online all the time. So we're developing some training on risk at the moment. So that's going to be on the webpage soon. The link to that. So and we've recently put some blogs on. So there are additional resources that we're adding to our webpage as we speak.
Yes, the e-learning on risk is being created currently with our learning technology team, which will be a resource for everybody across NHS Wales to access. We will definitely be, if you are watching this and you are interested in having access to that resource, we can certainly make you aware when it is available and finished. And if anybody would like to test it out, we'd be we'd welcome beta testers to run through it to make sure that it's user friendly and creates the right learning outcomes, the right intended outcomes.
Yeah, so the full training is actually over 2 days as well, we should mention. So it's a full 2-day training. So it is quite a commitment for health authorities and for staff, really, to commit to attending 2 days of training. Okay, so thank you very much for your comments in the chat bar there. That's very kind of you. And you're all very, very polite, I must say. No, there was no heckling, which is always a good thing. And so thank you so much for joining us today. And hopefully we might see you again in the future. Who knows?
Diolch yn fawr.
Yes. Thank you very, very much. So we'll close the session there, I think.